Huh?
Hello, everybody. Thank you for your patience. I think we're ready to get started. Yeah. So just to introduce myself real quick, my name is Ariel. I use she, her pronouns. I've been an ACT UP member since 2018, and I'll be one of the co-facilitators tonight.
My name is Jake P. Him. I've been an active member for a few years, but I don't know exactly how long. And we are here tonight to talk about some news about funding cuts to New York City's Department of Mental Health and Mental Health and Family Information. And so Ariel's just going to go over some basic ground rules, and then we'll get into the agenda.
Yeah, so whether this is your first or 500th ACT UP event, welcome to ACT UP. We are the AIDS Coalition to Unleash Power, a diverse, nonpartisan group of individuals united in anger and committed to direct action to end the AIDS crisis. And by attending this meeting, everyone here is officially an ACT UP member for life. Don't forget it. And yeah, and just some ground rules for ACT UP meetings. Try to remember that we are centering our anger towards institutions, not people. And we're also going to be mindful to keep a stack and to not speak over one another. And yeah, and just a reminder that we're all here for the same reason. We're here to ACT UP, fight back, and end AIDS. And with that, I'm going to hand it to Jake.
Yep. Just a couple of other technical things. This is a hybrid meeting right now, so if you're online, it's a webinar, which means I don't believe there's a chat, but you can type into the Q&A. And when we get to the public comment section, we will read your questions out for everybody.
We'll need Spanish.
We don't. We don't have an ASL interpreter, but there should be captions on the Zoom. So if you're here in person and you need support for that, you can just log into the Zoom and put it on mute, and that's what we can offer. And then also we wanted to acknowledge that we are currently in New York City, which is Lenape-Hoking, the ancestral lands of the Lenape people. And I would hope that at this moment in time, we would all take this as a second to reflect on the colonial history of the United States and how that might parallel with other struggles in the world right now. And Ariel is going to say something about that.
Yeah, so a lot of ACT UP's focus recently has been on our Fund Healthcare Not Warfare initiative, and I just want to begin this meeting by acknowledging the over 40,000 people who have been massacred in Gaza by the IOF, and we're going to talk today about some healthcare funding cuts local to our city, but I want us all to remember that while we're cutting millions of dollars for funding for all of these really important healthcare initiatives we're about to get into, our tax dollars are being sent in blank checks to the Israeli military to commit a genocide against Palestinians indiscriminately of their gender, of their sexuality, of their HIV status. And we know that the displacement of millions of people living in Gaza is a healthcare issue. We know that famine is a healthcare issue. And we know that even beyond all of these crises happening in Gaza being healthcare issues, we know that this is our duty as people of human consciousness to speak out against this genocide. And thank you all for being here as we hold space for that.
You gonna move the slide forward now? So we just want to give you a rundown of how this meeting is going to play out. First, we're just going to give some basic information about what ACT UP has been working on that's related to these budget cuts, so that we're all kind of on the same playing field. During that period, if you have any clarifying questions, it would be great to ask them. But as soon as we're done with that, we're going to move to public comment, and that's where I hope you will save most of your statements, opinions, questions to politicians, DOHMH, whatever. That's really what that is for. We do have a slight deviation from the agenda, I think, though, because I believe that maybe Eric Botcher wanted to make a statement, but is only available until 7:15. So, is Eric on the line and can speak? Not to put you on the spot, but.
Hi, everyone. Can you hear me?
Yes. Yeah.
Oh, hi, everyone. Really appreciate the opportunity to be here and talk about the $5.3 million in cuts being pushed by the Adams administration in this budget and our efforts to get these clawed back. The cuts include cuts to many programs that have been successful in helping us bend the curve on the pandemic, and including like $1.6 million directly to programs like the Undetectables, crystal meth harm reduction, HIV prevention and literacy, older adults programs. These are the programs that we've built up for many years that have helped us bring down the zero conversions in our community, help people adhere to treatment. And I want to ask for your help and explain to those of you who might not be familiar a little bit about how the decisions are going to be made. The budget is in the process of being negotiated between the city council and the Adams administration. We have, per the city charter, until the end of June to pass the budget. And the way that it has played out so far, this year, the mayor proposes a budget. The city council responds to that budget with our proposed budget, and then the mayor responds with his final revised budget, and that's what we're responding to. And he has basically said to all agencies that they have to find savings, and the health department has chosen these programs among the programs to find savings. So now there are conversations happening and negotiations happening between the city council and the mayor. And at the city council side, those negotiations are made by the speaker's team and but the budget negotiation team, which is a team of council members appointed by the speaker that get into a room and discuss what priorities the council should push on. And they'll put up on the wall, on the projector, they'll say, so here's how much money we have to play with, like what programs should we save with this funding? What programs should we get back to the administration with, get back to them on and say, these are the programs that we want to save. So we want these programs to be the programs that the council advocates for. The LGBTQIA plus caucus, we did to Mayor Adams last week. There was a Gay City News article about these cuts last week. I'm going to be doing an op-ed in the next few days about these cuts. And I've spoken to Speaker Adams about these cuts, and she expressed to me that she also believes that they should be reversed. I've been in touch with Lynn Schulman, who, in addition to being a member of the caucus, is the chair of the health committee. She's on board with getting these reversed. And I believe that the finance chair, Justin Brannon, is on board as well. But I think in the weeks ahead, these cuts need to be elevated in the discourse. And I think, I was sort of put to you how you think reaching out to the powers that be, how you would like to do that. We are planning a press conference on the steps of City Hall on June 11th, working with GMHC and other groups. So we'll definitely be sending you the information for that. I don't know if you are passing resolutions or writing letters to take an official position on things, and reaching out to all the different stakeholders to make your positions known. I think your voice is very powerful, and you have a great deal of credibility with respect to these issues. So that's why I appreciate the invitation to be here, and I appreciate the opportunity to speak to you about these. I do feel like we could get these reversed. I do believe that. We just have to make sure that people know that it's a priority. Thank you so much.
Thank you. There's one thing I just want to point out as well. If you look at our agenda, you'll notice we're not only talking about the HIV cuts, and maybe someone in the back from DOHMH can give me a thumbs up if I have this number right, but I believe the health department is actually facing $75 million in cuts, and it's the HIV program that is $5 million. Is that sound right? Yes, that's right. So you'll find throughout this meeting that we're going to talk about a lot of things, and not just the HIV program, but that is very important. And now I'm going to pass it over to Ivy Arsa, who's a long-term HIV survivor, and will help to kick off the meeting proper.
Mike, if you could go to Ivy's slides, and there should be next. Yep, great.
All right. Thank you for coming into this room specifically. This is the active room since the late 80s. We formatted the same room the same way we used to meet for the information table. So let me start with fund healthcare and not welfare.
We're anti-welfare now.
Warfare. My name is Ivy Kwan. I go by Kuri Aya, she, her. So I've been an active member since 1999.
You move it.
Oh, I'm moving forward.
Yeah.
Sorry, I'll do this. I'll do what? The slides. What? There was a second slide. Yeah. So I'll just say, next slide. So I'm gonna just share the importance, obviously, as what I consider that we're an investor as HIV positive people and AIDS activists in this city that is modeled globally our contributions to science and health equity. I became positive in 1990 actually through an action of ACT UP, and I saw a weak face poster in the subway done by the women's working group at ACT UP, and it was pre the visual, so it was just the action poster, and stated women don't get AIDS, they just die from it. So I went and profiled the fine print, and I said, you may not think that you are affected, but if you have multiple partners or somebody in your circle is an IV user, you should test. So I went to my doctor asking for a test, and in 1990, actually, they did not have a test in the office, and there was a challenging moment where they had said, we don't test women, why would you ask us that? So I requested it, and they finally found a way to get me tested. So when the test came back, even the doctor said, oh, maybe it's a wrong positive. We'll redo the test, but in the meantime, I don't have any referral for you. I've called a couple people. At this point, we didn't have really what we call AIDS doctor. People were becoming AIDS doctor. So he said, well, in the meantime, while you're waiting, why don't you actually go to that place where you saw the poster? And it was this room. So in this room, I had basically connected with people that taught me how to navigate finding doctors, learning about the virus in general, and mostly helping other people die. We used to come to this meeting, and we started the meeting with a list of people that were in the hospital that week. And the next list was the people that were in the list last week and that didn't make it the following week. So this room, this membership that I'm in, is a membership that also help women with AIDS fight a lawsuit with the state about having a definition for HIV positive women, because we were not defined under the government to have insurance coverage, and it was we didn't have a definition of HIV. So the lawsuit we won and included women-specific illness and the 200 CD count to state that you were positive. So that definition also benefited the men in terms of making it clear for insurance company to not deny them for treatment. So that's the kind of investment we have worked through in the last 30 to 40 years. Next slide. I continue to be in ACT UP. I've been coming in and out. I came back during 2011 when a lot of people were getting infected, the younger generation, and worked on PrEP. There's an arm of ACT UP that focused in science, and it's called Treatment Action Group, which I'm actually the board president. So hard to we're in the next slide now?
Yeah, you're on the science one.
The science one. So I'm here to speak about the profound arc now that I have 33 years of being a positive person. And this is what I call what this impact of this, any cuts of HIV. So our investment have been with our own body. We're a community that had a moment with so many of us died, but we actually invested in all the clinical trials with our own bodies, made treatment safer, push science to push their limit. And, I guess the next slide will explain. Yeah. So this one, yeah. So that investment, obviously, as for those who are much younger, I would say like something that's tangible is that COVID vaccines and treatment is part of that investment, including what I wanted to highlight is that a lot of people don't know that the NIH Vaccine Center did not exist until AIDS activists not only demanded it, but kind of implemented it. So we wouldn't have, SARS and all these other things that we're working on. And for me to witness another, I think, ironic thing was that the treatment for COVID, Paxlovid, has like a 1996 HIV drug. So I really enjoyed, not enjoyed, when actually Fauci had to take it, and he had a rebound and had to take it twice. So I guess my point is that that DNA or investment now is across the board globally, and I just want people to recognize that. And when the city cuts those funds, it's like it's cutting a major investor into science and health equity. The next one. Yeah, so we're in this. Okay. So the cuts, I'm going to specifically talk about like long-term survivors, what it means to us, right? A lot of us are defined by long-term survivors are the people that did not have heart, which means that we didn't have any medications in. And a lot of us have like extremely immune compromised, but yet we have used all that information to benefit everybody else. And particularly, I want to elevate the people that were born with this virus. Now they're in their late 20s, 30s, 40s. They're citizens that have survived against a lot of odds. Medications came late to them. As their formulations for children, came along a lot later. They continue to live, those who survive them now still live with a very compromised immune system. And they don't fall in the category now that just we have medication and everything's okay with them. So that would affect them a lot. For aging long-term survivors like myself, what we see is the HIV specific doctors for elderly are not informed enough, and I will just share a very story. For example, in New York, always in New York, I always think that we're so on top of it. So in 1999, when I decided to become a parent, because I think the first slide said, I've been positive since 1990, but it was a person with AIDS for 7 years. That doesn't mean when we didn't have medication. After, when it was safe, I was able to take medication, and I decided to invest on a drug that the viability of a drug that was cheaper than the protease because we're using globally. So I made a decision to take a lower drug because that's the drug that people give globally. That cuts HIV transmission during birth 85%, and I took it for 7 years so they wouldn't take it out of the market. So that story is that, even then, even being positive for so long, I couldn't find an OBGYN that would actually help me carry to term. So even in this beautiful city of New York City, there's a lot that hasn't changed. On to today, fast forward to a couple months ago, I had a new OBGYN that she was asking me what kind of protection I use, and I said I don't use any because I've been undetectable for now, 27 years. And she said, oh, maybe you should talk to your HIV doctor, so that U equals U is not even informed in you today. Retouching a little bit about the investment about long-term survivors, I also want to express that the work of HIPAA protecting patients' rights has a lot of the work that HIV positive people have done. The discrimination that happened to gay men mobilized to change that, and that didn't really exist, the kind of patient rights that when you guys go to the doctor have to sign, including the notion if you're a gay man that equals that you, back then that would equal that you had AIDS. And if you did have AIDS, we did challenge the insurance would not cover us. So that was an investment that everybody benefits these days. Am I on the next slide? So last year there was this exhibit, and it highlights the contracts of when we're talking about budget. We spend $29 million a day policing in New York City. That's a day. Next slide, please. Oh. So the agency operating budget reports that, and this is a little late, a year later, right? That between all the benefits and all that, the city spends $10 billion, $10.8 billion, and the cost for the police. their pension and everything. So when they want to cut 5.3, it's just utterly ridiculous. Next slide. So so this 5.3 significantly impacts long-term survivors, and also, I didn't put this, but also the escalation of people seroconverting as well, and the ongoing STIs and not being able to get Mpox vaccine. So I think as a group, we're opposed obviously to the cuts, but we actually demand a budget expansion for HIV service. Oh, and the last one was my reference, but it didn't make it to the slide. It's all true.
Believe in it.
Women do get AIDS. Oh my God, I'm sorry. But somebody has the slide somewhere. I have it here in the computer, but it's all true. So the last slide. Yeah. So thank you.
Thank you so much, Ivy, for sharing your story and reminding us how we got here and the importance of HIV funding and how that truly benefits all of us, regardless of our status and regardless of our age. And as we now move into more, so now we're going to talk a little bit about the budgeting, and then we're going to go into these different topics that Ivy touched on, and to talk about budgets. I'm going to pass it.
Yeah, so Seth Pollock from Housing Works, I believe, is on the Zoom. We can, if we can get him a mic. Otherwise, we'll go back to this one after the next speaker. How are we looking back there? Thumbs up, okay.
We are, I'm not seeing a Seth Pollock in the guest attendee list.
Yeah, hand raise.
Yeah, they're there.
So I can see.
You should just be able to click allow to talk.
Go ahead.
Hi all, I'm Seth Pollock. Zoom is not letting me put my video on for whatever reason, so you can enjoy my still photo for the moment. Thank you all so much for letting me be here and be here remotely. Honestly, Councilmember Botcher said things, first of all, that I was glad to hear him say. I didn't know that he had spoken to the council speaker recently. That's encouraging for me to hear. And I'm glad that he mentioned that we are planning a rally at City Hall, among other actions in the days ahead. By other actions, I don't want to be cryptic. We're thinking about things from appearing at Pride events as borough-based Pride events happen, as well as potentially flyering around City Hall. A fun fact is that our city council has their offices just across the street at 250 Broadway. So all day, let's see. All right, I still can't turn my video on. It is what it is. All day, there is constant traffic of our city council members going to and from City Hall and their offices at 250 Broadway. So a few people there who care about fighting these cuts, firing, can have a real impact. I do want to share a really easy thing that we all can do now. I'll drop a link in the Zoom for other folks who are on Zoom. If you are in the room, you can open up your web browser on your phone and go to bit.ly/actupstopcuts, all lowercase, all one word. bit.ly/actupstopcuts. This is a really, really simple tool that will let you input your address to find your city council member and email them, pushing them to oppose these cuts. As Ivy pointed out, the amount of money that the city quote unquote saves on the front end through these cuts is minuscule compared to things like NYPD overtime. So it's really, really deplorable that the mayor would try to balance the budget on the backs of people living with HIV or who are at greatest risk of HIV. So I'm also going to drop my email in the chat here, and for folks in the room, it's s.pollack, Pollack, at housingworks.org. We don't have much time. An important thing to note is that the city budget is due by the end of June. So every day is another opportunity to make some noise here. I want to be clear that we are hearing encouraging things, but for me here at Housing Works, opposing these cuts is just the start. There are so many other cuts that affect vulnerable people, by which I mean people who are living with HIV, people who are at risk of police violence, people who are homeless or housing insecure. We need to fight those cuts too. And we at Housing Works are working on that, and I'll try to be better in touch with you all about how we can work together. Thanks, everyone.
Thank you so much, Seth. We'll be making sure to head to bit.ly/ActUpStopCuts. And yeah, we'll be making some noise till the end of June, right? People in the room? Yeah? Now to get into some of the topics that we discussed, I'm gonna pass it to Nia to talk about sexual health clinics and how we got here.
Hello. My name is Mia, and I use they, them pronouns. You can go to the first slide. This town hall came together because during the course of working on our annual Pride Health Fair, we realized that our free and public city health services are in a state of emergency. For the past 4 years, our health fair, which happens on June 30th, or Pride Sunday, in front of Jets Memorial Church at Washington Square Park, has been a collaboration with the Department of Health to provide free services such as HIV testing, COVID and Mpox vaccines, drug test strips, and PrEP consultations to LGBT New Yorkers in the kind of high-volume congregate settings where they need them the most. So one of our first steps this year was to reach out to the Department of Health's free COVID Express clinics to invite them to table and provide COVID, RSV, Flu A, and Flu B testing services on site during Pride. Next slide. At the time that we began working on the health fair this February, which was the tail end of the JN1 variant, which caused the second largest COVID spread in the US since the start of the pandemic in 2020, there were only 4 Department of Health COVID PCR testing centers in all 5 boroughs. 1 in Jamaica, 1 in Mauritania, 1 in Harlem, and 1 in Brooklyn. As of today, only 1 of these clinics remains, the one in Crown Heights, and without the efforts of those of us in the room here today, it is set to close in June. Next slide. But COVID spread remains a constant in our day-to-day lives, and this clinic's proposed closure is happening at a time when national wastewater numbers are rising again, indicating an incoming summer surge. The Mauritania COVID clinic closed first in March. After its closure, I reached out to the manager of the Crown Heights COVID clinic, which had also been the site of an abortion STI clinic before 2020, to inquire if the COVID clinic's closing was due to the reopening of the abortion STI clinics, and if the funding pools for COVID and abortion and STI services were being pit against one another. Next slide. The manager was able to confirm that the COVID clinic functioned by using temporary staff, and after its closure in June, they would begin a 6-month process of hiring full-time staff to the abortion STI clinic, which has been sitting empty since 2020 on the 2nd floor of the same building since COVID services began on the floor below. But Mpox cases are on the rise and are likely to peak this summer, and if this clinic stays closed until winter, Brooklyn will only have 1 STI clinic during this oncoming surge. All of this is a total tragedy that must be stopped before it goes into effect. Each borough deserves abortion STI services and COVID services in the same building permanently for as long as COVID and STIs continue to spread, until HIV is cured, and as long as people continue to need birth control and abortion STI services. We must maintain the staff at the Crown Heights COVID clinic and hire temp staff for the abortion STI clinic in the interim of the permanent staff members incoming this winter, in order to have the clinic stay open for these busy summer months. We must reopen the 3 recently closed COVID Express clinics in Jamaica, Harlem, and Mauritania. No one should have to choose between accessing abortion, STI, and HIV services and accessing testing and treatment for COVID, especially when COVID creates extra complications for those with chronic health conditions like HIV and for those who are pregnant. Next slide. Slide after this, sorry. Yeah, this one. Okay. I want you to take a picture of this slide. I can send this right. All right. So we need the help of the officials in this room today to strategize with us so that no New Yorker is forced to make the kind of decision that I just mentioned. These Department of Health abortion, STI, and COVID clinics are important because they are free without ID or insurance. They are the only places for low-income, uninsured, migrant, unhoused, and underinsured New Yorkers to access these services. We need the city to keep them open, give them expanded and weekend hours, and to do outreach and advertise them on the subway, on billboards, in shelters, at prison reentry services, and in different languages so that people who need them the most know that they exist. If they're allowed to close or stay closed or maintain their limited hours, there will be nowhere else for this very large demographic of patients, including myself, to go. Thank you.
Thank you so much, Nia. And with that, I'm going to pass it to Brandon to speak about MPOX.
Test. Okay, great. Hi, my name is Brandon. I use he, him pronouns, and I'm going to give a quick overview and a bit of a history of MPOX over the last couple of years. We can go to the next slide. So many of you may remember 2022 was a big introduction of the last few years to MPOX. After cases first appeared in New York City in May 2022, positive MPOX cases climbed to between 25 and almost 100 per day in July, a couple of months later. First dose vaccine distribution peaked the next month in early August, and by the end of the year, 102,183 first doses of the vaccine had been administered. Unfortunately, of those people who received the first dose, only 52,374 people returned to receive the second recommended dose of the MPOX vaccine. And by comparison, in a 2020 study, DOHMH, the Department of Health and Mental Hygiene, had identified 134,000 people, which at that time it was primarily men who have sex with men, or MSN. They had identified that number as at heightened risk of MPOX infection. So even by DOHMH's standards from 2020, essentially less than 40% of people at high risk of MPOX were fully vaccinated in 2022, because you need both doses to be fully vaccinated. Also keep in mind that in New York City, we have 700,000 people who currently identify as LGBTQI. Next slide, please. So, I think going out of 2022, I think we felt like we were in decent or good enough shape for 2023. That proved mostly true. We only had 184 positive reported cases in all of 2023. Next slide. And then cut to 2024, when we start seeing cases creeping up a little bit each month. So January had 49 cases. Next slide. February had 34 cases. March had 49 cases. April had 53 cases. So already through April of this year, we're already above all of the cases from 2023 combined, 185 positive reported cases. And next slide, please. The next slide is mpox transmissions, because those numbers are likely low numbers, right? We can assume that there are many more mpox infections than reported due to a number of reasons. One of them is lack of messaging or misinformation. In 2022, the messaging was very heavily aimed at and catering to gay men, essentially. Gay men were the first men who have sex with men. We're the first people who were allowed access to the vaccine. If you did not identify as a gay man or an MSM, you probably had trouble getting the vaccine for weeks or maybe even months. So because of that, now in 2024, you may think back to those days and think, oh, well, I'm not a gay man, so this can't be monkeypox, or it can't be mpox. The next thing is that people don't necessarily know where to get tested, especially if they're uninsured. And just like Nia was explaining about the closed clinics, our STI clinics are overburdened. They're only open 9:30 a.m. to 3:30 p.m. If they run out of vaccines or services, you may be asked to reschedule at a later date. And then also the stigma of mpox still, I think, remains for a number of people, partially because of that initial push to focus on gay men and that behavior. I think a lot of people who may have contracted mpox, there's a stigma of being gay or having sex with men, which is carried with it. So I think that relates to people being maybe reluctant to admit that they're positive for mpox or to get tested, because then they would be admitting things about themselves. And then we still have a high unavailability of TPOXX. So I know TPOXX is the treatment for mpox. Back in 2022, it took doctors had to jump through a lot of hoops to get people TPOXX. And a lot of people never saw it or never got it, and doctors didn't always know about it. They didn't want to deal with the cumbersome process to get TPOXX. I think even now it's supposedly the process is a little bit better, but not all doctors know about TPOXX. And I think it's still technically it's being studied. So you have to basically enroll in a study and answer a bunch of questions to be monitored to get TPOXX. So it's something that like both people and doctors themselves may be a little bit reluctant to do just because it's time intensive. And then you have another big reason why people don't necessarily report that they might have mpox is that the standard procedure, if you were found to be positive back in 2022, was quarantining and isolation. So for many low-income people, that meant missing work, and we're talking like weeks of work. So not everybody's able to do that. So there is a definite reluctance to get tested and come back with that positive mpox case, because you could be asked to stay home from work and essentially lose money because there's no coverage for losing weeks of work due to contracting mpox. Next slide. So coming back to 2024, what is the strategy for 2024? Is it 2022 all over again? We hoped not. I'm part of the group that organizes the health fair every year. This year on June 30th, down in the village below Washington Square Park. We met with DOHMH and explained, how each year we try to bring vaccines, whether it's COVID, mpox, hepatitis, to our health fair, and we specifically brought up mpox. And it was pretty clear from our first meeting, because we asked, what's different this year, and how has the strategy changed? And it was pretty clear that it has not really changed from 2022. And the very reactive approach in 2022 of, this huge surge with thousands of cases, followed by, then securing the vaccines and getting them to people and distributing them, that basic process kind of remains in place for 2024. Nothing is different whatsoever. There's no, stockpile of vaccines kind of sitting by waiting to be accessed. There's no distribution, there's no new distribution channels basically in play. And that's because it's all reliant on the FDA and Health and Human Services enacting emergency use authorization. So the only reason people got vaccinated in large numbers in 2022 was the emergency use authorization. And without that, basically, it's not clear really if DOHMH has a plan, if that's not in place. There's no like stopgap, there's no plan B. It's like, wait for the surge, hope the FDA and HHS calls for emergency use authorization, and then the vaccines are released and they can be distributed throughout the city. Which is kind of scary. We were hoping for more, and as a result of that, we are having a hard time right now lining up our mpox vaccines for the clinics for the health fair at the end of next month, because even our providers, community providers like Housing Works, Callan Lord, our regular providers, they can't guarantee the vaccine in 4 weeks. So even though we've been talking to them for weeks and in some cases months, they can't necessarily say that they can't guarantee that they won't run out of the vaccine by the end of next month, which is really troubling because the whole point of the health fair is that we have these large congregate settings which serve as such a great opportunity to reach our community. People can see people getting vaccinated. It's a great messaging tool for our community. So we can go to the next slide. Okay, so I had actually made this slide originally I had this slide with a bunch of questions, and then somebody was like, oh, come on, we're act up, like, make them demands, make them demands. So yeah, they're formed in the phrase of a demand. And I think the first demand has to be that DOHMH do recognize publicly that we are experiencing an mpox outbreak. The winter months are always the slowest months for STI infections and transmission, and we can only expect more infections as we go into the summer. So I think that's the first thing that has to happen. On the heels of that, I think if DOHMH is going to rely on this emergency use authorization, and that's basically the only thing in the toolkit, and the toolkit hasn't really grown, then I think DOHMH needs to be lobbying either the White House, the FDA, Health and Human Services, the CDC might be able to help too, lobby for this emergency use authorization that's going to free up all this federal money and increase the vaccine supply. Without it, until that happens, nothing's going to happen. So these infections can sit at 50, they can go up to 100 a month, they can go up probably even higher, but nothing's really going to happen. The supply's not going to change if we don't get that emergency use authorization. And then I think we definitely need to reestablish vaccine support and roll out proactively for all high-risk populations. We know a number of communities were not reached in 2022 due to a lot of things, and sometimes language barriers being the issue. And so we have to be very proactive about reaching those communities because they're the ones bearing the brunt of mpox transmission right now. And then I think the other big thing that's happened in the last couple of months is the reason that our community providers are having that shortage of mpox vaccines is DOHMH is unable to supply them anymore. Basically, the mpox vaccine, which is Jynneos, made by Novo Nordisk, has been commercialized. So now each vaccine costs over $100 a pop. And which, if you're a smaller community organization like Apicha, Callan Lord, maybe even Housing Works, they basically can't afford to just give away hundreds of vaccines, in a month, even if they did have them. So I think DOHMH really needs to figure out the long-term plan and funding stream that's going to make sure all of our providers are stocked with vaccines. And then I think it's just really important for DOHMH, to come up with a long-term plan for the city as far as addressing these disease outbreaks when they happen, being proactive, not just retroactive, and show that it really is building upon, at least we have COVID and now mpox, building upon the failures and the lessons from those two pandemics. So yeah, I think that's really important. Is there another slide? Nope. All right, that's it. Thank you very much.
Thank you so much, Brandon. I'm now going to pass the mic to Casey, who is going to speak about COVID-19.
Hello. Just want to say thank you, everyone. Thank you for coming out. Thank you, Ariel, for facilitating. Thank you, Jake. Thank you, Nia. Thank you, Brandon. And thank you, Scott, preemptively. And thank you, Mike, for doing time. So let's talk some more about COVID. We'll be repeating some things that Nia said, but I'll go some more in depth to it. Next slide, please. So just going to give you a little roadmap. We're going to talk about the current prevalence of COVID-19 and long COVID, how to prevent COVID-19 transmission, and what can you do, or what can we do. Next slide, please. So, in the past 4 years, 1,191,387 Americans have died of COVID-19. There have been 7,049,376 confirmed deaths worldwide. That is an undercount. The estimates range from 10 to 35 million. And those estimates are from like the World Health Organization and from The Economist. 1 in 10 COVID infections leads to long COVID. 1 in 10. And that includes reinfections as well. Next slide, please. So, in the past year, 60,405 Americans have died of COVID-19. Again, that is confirmed. Those numbers are definitely an undercount, but that is the number that we know of. The official counts of hospitalization, cases, and death are no longer accurate as the infrastructure to count this data and collect this data has been systematically removed. Just starting this month in May, hospitalizations are no longer being reported to the federal government. Hospitals are no longer required to report the amount of COVID cases they have. We do not know how many people are hospitalized with COVID right now. We don't know. This number will continue to grow unless we focus on prevention. And I do just want to point out that it has been about a year since the federal emergency has ended, okay? The federal emergency ended on May 11th. The 60,405 deaths, that is as of May 18th. So that is a year of normal times. Normal COVID now. That's what this is, that's what the future is. That's normal. Next slide, please. Immunocompromised people have been left behind. Immunocompromised people are at an increased risk for severe COVID-19 outcomes, even if they are up to date with their vaccines. Just one prior COVID-19 infection can make you immunocompromised. COVID-19 can still kill, hospitalize, and disable anybody, regardless of age, prior health conditions, or vaccination status. Next slide, please. There is one free COVID testing site in the 5 boroughs. This is what Nia said, and so I just wanted to remind everybody, here it is on the map. It is like an hour and a half from people who live in Inwood in the Bronx. And that is the only place in the entire city where uninsured Americans can get or uninsured people in the city can get a free COVID-19 test, a free influenza A and B test, and a free RSV test. Okay, and that is a PCR test. So the negative results on a PCR test are up to 99% accurate. That is compared to the negative results on a rapid antigen test, which is the little one that looks like a pregnancy test that you get at CVS. Those for a single test are only 30% accurate. And you're supposed to take 2 of them over the course of like 2 days, and nobody does that, but you're supposed to do that. And that's like 68% accurate. Positive results are required to access Paxlovid, which helps prevent deaths, hospitalizations, and long COVID. And as Nia said, this testing site will soon close in June. Next slide, please. Uninsured Americans are also about to lose access to vaccines. So remember, when the pandemic began, we had Medicare for all, but for COVID. Like for this one thing, we had Medicare for all. And then when they were done with that, there was still a way for uninsured Americans to get free access to vaccines. That was the Bridge Access Program. We could talk about whether or not it was good, it hit or miss, but it's going to end soon as well. After that, there will be no way for uninsured Americans to get a free COVID vaccine. Annual or biannual, that's twice a year, vaccination is critical to maintain immunity, which wanes rapidly. New variants are consistently evolving to evade immunity from prior infection and immunization. And I just want to highlight that these aren't really boosters, these are updated vaccines because they change the vaccine every year to match the newer variants. Next slide, please. Healthcare settings present an increased risk without universal precautions. So hospital-acquired COVID-19 infections are more fatal. They have a 5 to 10% mortality rate. You can't just avoid a healthcare setting, right? You have to go to the doctor, right? Or there's going to be negative consequences, especially if you are immunocompromised, especially if you are disabled. Masking is no longer universal in healthcare settings, and facilities do not meet the ASHRAE 241 ventilation standard for control of infectious aerosols. And this has impacts beyond COVID, right? Because COVID's not the only airborne virus, right? Airborne precautions, masking, proper ventilation, they help prevent things like measles, the flu, all of those things, all of the things that people in hospitals have that can be spread, they prevent the spread of them. It should be common sense. I don't know how we came out of the past 4 years and we haven't decided to implement universal masking and ventilation in hospitals. Next slide, please. As I said before, 1 out of every 10 COVID cases leads to long COVID. 300,000 New Yorkers have long COVID, and this is certainly an undercount. This is based on the 1 in 10 statistic and about 3 million New Yorkers having confirmed positive COVID-19 according to the city's data. Long COVID is an umbrella term. There are over 200 symptoms. COVID triggers several autoimmune disorders and syndromes. And there are long COVID clinics in the city, but there's little outreach being done for them. Each facility would need to take on 22,000 patients at minimum to cover our conservative estimate of the amount of New Yorkers with long COVID. Next slide, please. Right now, people with long COVID have few options. There's very little awareness of long COVID. A lot of doctors don't even know about it. Several people don't even know about it. Nobody knows, not nobody, but a lot of people don't know how to diagnose it or where to send their patients that have it. And the number of people with long COVID is only going to continue to grow if we don't do anything to stop the spread of the virus. Next slide, please. This is preventable. Here's some data on masking and how effective it is. So even the cloth masks are effective to a certain degree in preventing the transmission. Surgical masks are a little bit better, and N95, KN95 respirators are even better than that. Next slide. Do something. I made these demands and then was told to make them questions, so the opposite of what happened to Brandon. But so New York needs to, now I'm making them demands. New York needs to expand access to free testing, treatment, and vaccination. New York needs to enact universal masking and proper ventilation in healthcare settings. It needs to expand long COVID research and support people living with long COVID. And we need to do our part to stop the virus that has killed nearly 1.2 million Americans in the past 4 years. I just realized I forgot to introduce myself. I'm Casey, my pronouns are he and them.
Thank you so much, Casey.
What's your name again? Slow down. Slow down. We're not all young and perky.
My name is Casey, and my pronouns are she and they.
Thank you so much, Casey. I'm now going to pass the mic to Zev, who uses he and they pronouns, who is going to cover our last topic of this segment of the town hall, which is condoms.
Hi everyone. As the last person in this segment and the one to talk about condoms, let's wrap this up. Get it. So what I'm here to talk about is primarily the New York City condom availability program and the gaps that we've seen recently, specifically in accessibility in our career spaces. So for some background context, the condom availability program has been at least servicing queer bars since 2005, and since I should just read this. I wrote this. So the condoms being stored in fish bowls and in buckets at the exits of queer bars have been provided for free, along with other safer sex products. Yes. Thank you. Condoms have been provided by New York City since 2005 to our queer spaces, and are serving an important need, being right at the place that they are most likely to be used. We know that we have a lot of community members, especially Black and brown folk, who either don't trust the community healthcare system, or people with varying immigration status that have reasons not to go to the healthcare system. and we need to ensure that they all have access to condoms as well. Unfortunately, what we've been seeing, at least in the past year, is a lot of our career spaces have stopped receiving these safer sex products. We are going around in bars and asking if the city has provided any shipments, and a lot of them have said they have no idea. That last shipment may come even a year ago, giving credit to AFDUC member and nightlife worker Butch Molly for being the first to raise or flag this issue, leading us to start canvassing and figuring out what was going on. We figured that it had to do with the egregious budget cuts that we've been talking about today, and we also thought that just because of COVID, a lot of things or programs have been lost in the shuffle. We then, as a result, formed the condom working group, and decided to dig into what was going on. We got in contact with the people at DOHMH, Alona Charkow and Saida Bakari. Alona, thank you for being here. And just to see how we could partner, we're really grateful that y'all wanted to partner with us so that we can better protect our community. Through that, we had essentially found out that the reason, yes, was because of budget cuts, but there were also just lapses in contracts and in vendors that led to a lot of our career spaces, 300 actually, being completely left off of the list of getting product. So the infrastructure exists. In 2007, millions of male condoms were distributed a month by this program. And we know that it is there to support our community, and it is being criminally underused. We can thank AIDS activists of the past for their work to getting to the point where we can have a program like this as a tool to use to protect our community, and its underutilization is really depressing. Right now, it is actually logistically or politically, bureaucratically, what have you, kind of an easy fix. We just need to enroll all of these bars. They fell off of the chart because they didn't auto-enroll, because they're in nightlife. When nightlife is communicating with any bureaucratic health government, they work completely different. They speak different languages. They work at different times. So there's some gap in the relationship that means that this auto-enroll didn't work. And this is especially challenging for bars that are not primarily English speaking, that are run by people who don't know how to work an online condom portal. And we ask the Department of Health and Mental Hygiene to strengthen and embolden their outreach. We as queer community members cannot be the ones to uphold this program. We need DOHMH to do the effective outreach, to go physically to these spaces and make sure that they are enrolled permanently in a program that frankly exists to protect all of us and should be used. Thank you.
Thank you so much, Scott, and to all of our speakers today. Let's give them a brief round of applause. Thank you for keeping us informed as we move on to our next segment of the town hall. Before through our website, next slide. And also we'll be having a bag go around for any cash donations people may want to give. And with that, I'm going to move us into our testimonial public comment section, which we'll have about 25 minutes for. And before we get that started, or
Probably more.
probably more,
We're not talking.
brainstorming. We want to end on action items. And so yeah, we're gonna have about 30 minutes for public comment. We just ask that if you are with the DOH or, okay, if we just ask that if you're with DOH or if you're, and I think it's too close to this mic, if you can just maybe move it back, right?
Yeah.
Yeah, I think we should move it further back. Okay. If you're with DOH or you're an elected official, please announce yourself and we'll ask you to go ahead of other people giving public comments so that we have proper time to address any of your comments or ask questions. And if you're in person and would like to make a testimonial or public comment, you can line up behind the microphone that's making a bunch of noise right now. And on Zoom, we will be fielding questions in the back.
Yeah, so just,
Yeah.
so if you're on Zoom, just put your question in the Q&A and we'll handle like a couple of them at a time depending on when they come in. But we'll either get you to speak or we'll just read them out depending on what you're comfortable with. You can write if you want to speak in the Q&A.
Yeah, so with that, if you have a testimonial, you can make your way to the microphone in the middle of the hall.
Well, so if you don't want to be filmed, just tell me, I'll turn away.
And if you don't wish to be filmed, just let us know at the top of your testimonial. We'll make sure you aren't recorded or filmed. And again, we ask that if you're with DOH or if you're an elected official that you go to the front of the line.
Hi, my name is Marcelo Maia. I'm the Captain New York also. In 2012, during the International AIDS Conference in the United States in Washington, D.C., Mark Harrington from Treatment Action Group and Charles King from Housing Works were arrested during a demonstration. And in the Padwagon, they came up with the idea to develop a plan to end the epidemic, AIDS epidemic in the United States. This. Hello? You are not on the phone.
Yeah, maybe just go to the podium.
Bring it back on.
And this mic does work. Marcelo, do you want to take this mic and take it to the podium?
How about if you want to speak, why don't we line up at this podium because this one doesn't have feedback and it's working. You want to come over here.
Or is that okay?
This one works.
Okay.
Yeah.
Thanks, Marcelo.
Right, it was working, right?
So they came up with this idea to end the epidemic in the United States. And from that, they pushed really hard, then Governor Cuomo, to convene a task force to develop a roadmap or a blueprint, actually, to end the AIDS epidemic in New York. The idea was to end the epidemic in New York in 2020. Of course, COVID hit, and that was the reason why it was a bit that we didn't hit the mark of 750 transmissions a year in New York City. Well, after the initial setback by COVID, this setback continued. Even though we said now that we're in the COVID pandemic, we're still far away from reaching this goal of ending the epidemic. So I would like, maybe we can ask Mayor Adams to really take this idea and compromising ending the epidemic. Go again to the plan to end the epidemic, and if you have to have cuts, look at the roadmap and the blueprint to end the epidemic in New York City. If you want to cut any program, do not cut programs that will affect the ability to reach the end of the epidemic in New York City. That's it here. If you have to have cuts, because if you're gonna cut, eventually you're gonna distance yourself and the city from reaching this goal, which how much? I mean, how long are we gonna be going through this? Year after year, nobody talks about any epidemic anymore. And I think that this is an issue that we should take with the mayor. Okay, thank you.
Good evening. Hi, my name is Dr. Celia Quinn. I'm the Deputy Commissioner for the Division of Disease Control at New York City's Health Department. I use she, her pronouns. I just want to start by thanking the organizers for inviting the Health Department to participate in tonight's event. I'm always delighted to be able to talk about issues that I care so much about with people who are equally passionate and driven to make the changes that we need to see. So thank you for including us. I don't actually have very much to add to what was already discussed related to the city budgeting process. I think this came up earlier, but the health department did have to cut $75 million from the health department budget, and that resulted in the cut of about $5 million related to HIV programming. These are really difficult decisions that we have to make, and I can only speak to what happens within the health department. But so just wanted to give some insight to how we think about how we approach those kinds of decisions. Obviously, at the agency level, we're looking to, find efficiencies in the budget that don't impact direct services to people. But with the size of this, change to our budget, we really had to make some very difficult choices that did result in some programs that do impact services to New Yorkers. And so, we tried to, some programs were eliminated, but we tried to also reduce ones where we could continue the same service, but maybe not at the same level. So anyway, really appreciate all the comments that happened earlier about, what ACT UP and others can do to, express your concerns about this. Next topic, I just wanted to talk briefly about MPOX. So appreciate the presentation about MPOX and the vaccine. So first of all, I would make sure people know that we did issue a health alert about MPOX and the continued increase in cases during the first part of 2024 earlier this month. One of the major issues is the commercialization of the Jynneos vaccine. So we learned about that very soon before it happened. This is a federal decision, and the vaccine became available on the commercial market April 1st of this year. We have been able to access some of the free federal supply, which is part of the federal strategic national stockpile, during this transition period of commercialization. And it's now our understanding that the federal government's expectation is that those federal supplies will no longer be available after August. So we have been working with the federal government to get access to those supplies to distribute to our providers here in New York City over the past 4 to 5 weeks. And we have had some good news in that those shipments were delivered yesterday and today. So it's not the amount that we initially asked for. And this push for commercialization is going to continue over the next couple of months. The good news is that this vaccine should be covered by Medicaid, Medicare, and other health insurance programs. We do offer the vaccine at our sexual health clinics, regardless of insurance status. Health and hospitals will also be offering the vaccine, regardless of insurance status. So certainly there are access issues related to the fact that this vaccine is going onto the commercial market and becoming part of the regular healthcare delivery system.
How many vaccines did we get from the national stockpile?
Just making sure that everything's on the mic. The question was, how many vaccines did we get?
I don't want to say a number that's not the right number, and I don't have it on me right now, but I think that the amount that we received will meet the needs of all of our providers that we're distributing it to for about the next 2 months. And we can order more before August. So, as providers are planning for events like the health event healthcare that people were talking about earlier, they can utilize those vaccines that they received this week for those events, and we can try to order more from the strategic national stockpile. But what we're working on with individual providers over the next few months is trying to help them order from the commercial market, make sure that they're able to bill insurance to get reimbursed for the cost of the vaccine so that they'll be able to fully be into the commercial market by August.
I also do want to clarify one thing about MPOX as well that might not have been clear from Brandon's presentation, that we did actually work with DOHMH to find a provider for MPOX vaccines for our healthcare. It's Ryan Health, I believe. Unless something has changed, I believe they're going to be able to. But it was very difficult to find somebody that basically nobody had vaccines that they could offer. So this is probably good news.
Yeah, I think it's a little bit a timing issue with the planning and the news about the commercialization and the uncertainty that we had about ordering during the past 4 weeks.
What's your name and title?
Sure, my name is Celia Quinn. I'm the Deputy Commissioner for the Division of Disease Control.
I'm sorry, Celia?
CELIA.
And what's your last name?
Quinn, QUINN.
It's Doctor? Thank you.
Is that of New York or the state or the federal government?
New York City Health Department.
Looks like we have a question.
Yeah, I have a question about the providing services but not providing them at the same level. Would the cutbacks to the condom program be an example of this? That happened going from having the contract with the guerrilla marketing forum to push out condoms to only having community partners to only having a website that's in English only? Is this like an example of that? Because we are seeing the effect of that. And it's not just like sort of making the barriers, the condoms are not a service provided for the bars. They're to get the condoms out to the places where they are needed. And by saying we're not providing the same level of access, what it's saying is the condoms are not getting to where they are most needed. They're going to the places that have staff that can log into the website and say, well, that's good enough, or staff that speak English since the website is only in English. Is this an example of that, of providing the same services but at a lower level? Is the condom program an example of that?
So when I said that, I was talking about the 5.3 million as part of the upcoming city budget that we were talking about earlier. I think some of the issues with the condom availability program, and I have a colleague here who may be able to speak to that in a little bit more detail, is not related to like that particular budget change, but to some other various administrative processes that have changed.
Would that be an example of providing services but not at the same level? Is that like we can expect more of the same of this kind of cutback?
So what the impact of the $5.3 million cut that we're talking about related to the upcoming fiscal year budget, there are programs that the health department has been doing where we had to reduce the size of the contract that we have with the contractor. So that may mean that a service is available in one location instead of 2 locations, or that's the type of change that I'm talking about.
Thank you for your answers. I'm Mike Sanders for that job.
Thank you, Mike. And if you could pass it behind you to Brian. And we'll take one more question after this, and then we will move on to our next public comment.
Hi, I had a similar question regarding, you said that when you're cutting these services, you are finding places to provide these services within other areas. What does that mean for the COVID testing clinics, which we know are closing, and there's not going to be no clinics whatsoever for people who are uninsured, underinsured, even just access, people who have access to timely PCR testing, which is so important in cutting chains of transmission. What is the Department of Health planning on to replace that service? Where are we going to see that?
Thank you for bringing up the question about the COVID testing sites. So all of our COVID Express testing was funded with federal funds that were part of the federal response to the COVID pandemic. And we are rapidly losing access to all of that federal funding that was supporting our COVID response. So that is why the COVID testing sites have been reduced in number. We do plan to keep the Crown Heights one open past June. So that one will continue to remain open as long as we continue to have the federal funding or funding to support the activities that are going on there. So, there are other, people can access COVID testing through visits to providers through the rest of the healthcare delivery system, including the public hospital system, H&H. But we are unable to continue to support the COVID testing operation once we don't have the access to federal funds.
Thank you. We'll take one more question. Ivy?
Hi, Cecilia. Thank you for saying yes and showing up. So what I'm interested as a stakeholder here is like, well, how can we be more proactive in between that pipeline of business between you guys and the federal government? Because that really is the thing.
It's such an important question. While we're talking about this topic, I also just wanted to mention, someone mentioned the COVID Bridge Access Program, which is the federal program for access to uninsured for COVID vaccines. We just learned about this being rescinded less than 2 weeks ago. Again, to find out now that it's happening in August gives us very little time to prepare and plan as a local jurisdiction. So, any advocacy towards the federal government to explain how that is impacting our communities, I think could be helpful. But ultimately, I think those decisions are being made at the congressional level.
And, we'll take one more question from Zev. And then we'll be moving on to our next public comment.
Was this is the feedback? Okay.
We're gonna banish that mic.
So in terms of monkeypox again, are y'all anywhere on a third dose? Is there any future where we can provide monkeypox boosters? There are findings, although seemingly not approved by CDC, that immunity does fade over time. and it is something that eventually may become a larger concern that if we don't get ahead of it.
Yeah, so currently the recommendation is to complete the 2-dose series and then be considered fully vaccinated, and there's no recommendation for a booster currently. The way that the vaccine recommendations work is that it's the Advisory Committee for Immunization Practices, which is an expert body that advises CDC on the guidance that they will issue. So I know this is something that ACIP will continue to look at and potentially change their guidance that way. So that's, I don't have any more insider information on that.
Thank you. We have one question online as well before we turn it over to the next speaker, which is how much money is in the NYC budget for COVID response, not including the federal funds?
I don't know the answer to that question.
Great, thank you.
Thank you. We'll pass it to our next speaker.
And while they're coming up, I also want to read one comment that we got online, which is, disability rights advocates are very concerned about police violence against people with disabilities and Mayor Adams' policies to sweep the streets and the subways of anyone suspected of having a mental health diagnosis. Can we come together to support each other's concerns? Mayor Adams' administration is cutting the voluntary medical services that New Yorkers need and funding a policing strategy that rests on civil rights violations. These are failures to respect the rights of New Yorkers generally and put our lives in danger. Now there's some grace.
Thanks. My name is Joaquin Aracena. I'm the Assistant Commissioner for the Bureau of Public Health Clinics, which the sexual health clinics live under. So I'll be speaking a little bit to address some of the sexual health clinics, and my pronouns are he, him. So I wanted to just first start off by just piggybacking off for Dr. Quinn on the COVID clinics. So as you all know, our sexual health clinics have always been a critical safety net for our community. Just to give you a little background, in the response to COVID, we converted our sexual health clinics to really be stood up as COVID testing sites for PCR confirmatory, right? So during that time, we responded to COVID and we started to pivot back to sexual health services. So that's why you're seeing some of our clinics that are closing down, because we're pivoting back to responding to HIV and STI during this time. And to Celia's point, few that have recently closed have been due to COVID funding. But we have 6 of 8 of our clinics that are open. We are open Monday through Friday, full service. We are providing evening hours on Tuesdays for both our STI Quickie location and Chelsea and at Fort Greene. Pre-pandemic, we did not have an STI Quickie clinic in Fort Greene. So the ability of these instruments, we are beginning to pivot them using the same instruments that we're doing PCR confirmatory testing for COVID. They have the ability to do for gonorrhea and chlamydia. So that's what we are in the process of doing currently now. And we have 2 locations that are providing that. Also in response, right, as a safety net, our sexual health clinics have responded to the overturn of Roe versus Wade, right, the medication abortion. So we are providing medication abortion at 3 of our locations. We've also expanded PrEP continuity within our clinics, which we did not provide PrEP continuity within our spaces. Corona Sexual Health Clinic is providing PrEP continuity. We are looking to explore expanding that to our outer borough clinics as well, to help fulfill some of those gaps. We've also recently rolled out doxycycline for PEP for STI, and we do have representation in 1 per borough currently now. So we do have at Morrisania, Corona, Fort Greene, and Central Harlem. So we are looking at ways to expand and to work with you all to continue to collaborate and partner with our partners to help fill many of the gaps. One of the biggest issues that we're having right now to be able to open the 2 remaining is vacancies amongst clinicians and nurses. So it's a challenge for us because we're competing with the big institutes that are able to provide higher pay for these doctors and nurses. So we are having challenges fulfilling those vacancies, which limit us from reopening Crown Heights and Riverside. But with your advocacy, your continued support, we appreciate your voice, we appreciate your concerns, and we're here to stand with you all and respond to ending the HIV epidemic as well. Thank you.
Could you spell your name, please?
Sure, that's Joaquin. Last name is Aracena, Aracena. And I'm the Assistant Commissioner for the Bureau of Public Health Clinics.
Is that a doctor?
No.
Does anyone have any questions or comments on? Yes, we'll pass the mic.
Hi, so since you mentioned PrEP continuity as like one of the services the city provides, I know the change this year occurred with Medicaid, where now PrEP requires a prior authorization, which it did not previously, and it requires you to be tested every 1 month instead of every 3 months, which is the recommended guidelines for PrEP. And this might be a bigger question than just the city, because I think Medicaid is probably a federal program, but like, why? How is that aiding access to PrEP for anybody with Medicaid?
Yeah, I can't answer that component. What I can say is that within our clinics, we do have patient navigators that are trying to work through the various systems to get individuals covered for PrEP continuity, and we're not able to get them coverage. And we do dispense from our own stock. We are a 340B entity, so we do provide PrEP to those individuals that can't afford or not able to get through insurance or coverage. And we have PrEP continuity currently at one location, which is at Corona. So not all of our sexual health clinics. So again, as we have funding, we're expanding services.
Thank you. And we'll take 2 more comments. Person right here and Maddie. Thank you.
Hey, thank you. My question, I guess my 2-part question is, like, I didn't know, and I guess I'm not sure if others did, but there of the uptick with COVID and the numbers so far. I guess because of the COVID fatigue and stuff, I guess I just haven't been paying attention. Is the city at some point going to recommend or address the uptick, and then how we should, I guess, move forward with that, either masking or with large gatherings we're going to have a bunch of large gatherings in June. And so is the city expecting a wave post-Pride events and things of that nature? I just want to know if the city's thinking ahead of what's going to happen.
Yeah, I can take that back. Again, I can only speak on behalf of the sexual health clinics. So we can definitely take that back and try to have a response for you.
Thank you. And we're going to pass now for our last question for you from Maddie.
Hi, thank you. I'm curious why all these services are kind of pitted against each other or separated and compartmentalized. And I'm wondering what keeps us from like having community care clinics that offer STI testing, prevention, COVID, Mpox vaccination, resources for housing. Like, I'm just curious what is keeping this very like specific versus offering broader support.
I think the biggest thing is funding. I think we continue to add on and enhance where we can. And many times, also within our specialties on what we can provide within our clinic space.
Thank you. And we'll move on to our next speaker.
Hello, mic check. Hello, I will keep this as short as I can. I'm not an expert, I'm not a doctor, I'm not an immunologist in any way. I read one book about the immune system, and it's actually a very good book. It's called Immune, A Journey into the Mysterious System That Keeps You Alive by Philip Detmer. And I powered through this book mostly until I got to HIV. And with each sentence, with each thing that I learned about HIV, I got so angry that I had to put the book down. I have not been so angry reading a book since the Bible. It was just so maddening to think that this thing that lives on a microbiological level is essentially the Thing movie. If you've never seen that horror movie with Kurt Russell, it's amazing, check it out. But essentially this thing pretends to be us, comes into our cells and tells everything in the cell, stop working, stop what you're doing, and make copies of me, and me, and me, and me. And it just keeps growing and growing until it finally cripples our immune system. And just like COVID, it creates immune-compromised people. And I'm seeing the same struggle that's going on with COVID as my mother saw in the 80s when she gave birth to me in 85, when Reagan and his administration would still keep quiet about HIV and AIDS for another 2 years because he believed it was a very efficient way of getting rid of people he didn't like, or that he didn't understand or didn't agree with. And so now, I, coming from a Texas background, coming from a Texan family that is uber racist, like, you call a cab and the guy shows up in a giant burning cross, like that kind of uber racist. And I have to have conversations with the people who believe that what I got sick with was a hoax, that I got infected and almost died from a hoax. I got 102 fever for 3 days. It was not a hoax. Now, I will say this. I caught COVID. COVID did not catch me. I wore a mask everywhere. I protected myself. I sanitized everything. And all it took was one luncheon that my wife had to do as part of her job amongst people who are in the top 1%. We're talking 1% of 1% wealthiest people here in New York who have top-notch healthcare. And this, as far as statistics, I love all the information you guys put up here, and I'm so glad. There's just one little thing I want to add to it. I've been watching the numbers every day since 2020. New cases, new deaths. I forced myself to watch this every day because I figured someday someone would have to remember. And as they started pulling all of the information, no more data was being collected. Over the last year, this may surprise you, but over the last year, more than half of the deaths here in the United States have been reported by Veterans Affairs. That means if 40 people die from COVID here in the United States, then over 20 of them are veterans. I have gotten more with my family talking about how we should be protecting our veterans than protecting just everybody. It seems that the conservative values, what they consider American values, are very, very specific. Christian, military, rich. That's it. That's, if you're not in one of those three categories, they don't care about you. And so by working with their own narrative, like, hey, I thought you said you support the troops, then why are you just allowing veterans to be marginalized by this and basically be on the front line again to fight a war that they did not sign up for after they've already survived a war to fight for our freedoms? Your freedom to live unmasked is killing those who fought a war to protect them, in theory. So we have to have these conversations, not just with ourselves, but with people that are not automatically going to disagree with us. They're automatically going to disagree with us. And I work in the entertainment industry. I work in theater, where my industry, I thought was going to be the last one to come back from lockdown. I thought we were going to have a vaccine. We were going to have everybody checked and make sure. No, it was almost as soon as the vaccine started rolling out, hey, let's get back to, mass groups of people, unmasked, out in the open or inside, no care. And so I was very shocked to find out that how many people I worked shoulder to shoulder with for over 10 years suddenly thought this was all a hoax, thought that me wearing a mask was in some way a protest. I wore a mask so that I didn't get sick, so that I could continue working, so that I could survive. But these are just some of the comments that I received. Take off the fucking mask. If they see you wear a mask, they're going to make all of us wear a mask. My mother died from the vaccine, and it was because of people like you wearing the mask that she felt pressured to take it. That's right. I've been called a murderer in not so few words, but still, like I'm responsible for somebody's death just because I wore the mask. I've also been accused of thievery. You could rob everybody here and get away with it because nobody knows what you look like. Yeah, except my employer who has my social security number, my mailing address, everything. So yeah, I could steal, but I would definitely get caught. But that's not what this is about. This is about basically, we have, in these cases that I've been monitoring, you have places like Suffolk County that have twice as many COVID cases, but a fraction of the deaths compared to, say, the Bronx, that had so few cases, but so many deaths. When I had to walk away from a job because they said COVID is an endemic, there's nothing we can do about it now, we're dropping masks. I said, okay, endemic just means poor person's problem. That those without the healthcare like Suffolk County, you're not going to survive this. And they don't care. That's the point. It's not about money. The reason why they're putting so much into the police and not enough into healthcare is because they know that they need to stay in power. And the only way they're going to do that is by giving the cops everything and leaving us with nothing.
Thank you so much for sharing. Thank you. We're, just so you all know, we have about 17 minutes left of our town hall, and originally we were going to have time for brainstorming public amongst each other for next steps. And I just wanted to kind of get a temperature check. Would we rather continue on for the next maybe 10 or so minutes and on testimonials and public comment, or would we rather have brainstorming? Could anybody who would rather have extend our public comment section further raise their hands?
Maybe we just hear from the last.
Yeah, there's two people online.
There's two more people? Okay, so I'm just gonna ask that you keep it to 2 minutes or less.
Yeah.
Thank you.
So yeah, I just couldn't let one of the last statements go about converting the COVID clinic back over to an STI clinic. That was always a poor situation that really did pit COVID against STIs. And probably 2 years ago, not necessarily right when it happened, but once people started saying that the COVID epidemic was winding down, cases were going down, people were getting vaccinated, ACT UP did ask DOHMH and did call for a vendor to be secured to conduct and resume STI services in a van or a trailer outside the closed STI clinic that had been converted to COVID. So, there was an answer to that. I think there was questions about, well, there's not enough space and we don't know about COVID. We don't want to have patients coming into a COVID clinic and we don't have the staff. It's different staffing needs. But there was an answer because we did the same thing in Chelsea with the STI clinic when that was closed for renovations for about a year. We demanded that a trailer be put outside and that Housing Works basically continue all the STI services while the Chelsea clinic was being renovated. So there is always a way to make these things hand in hand, for sure. And the only thing I want to say is that, the last thing I want to say is that I'm sickened that Mayor Adams is the one supporting and proposing these cuts after everything he's done over the past couple of years. The fact that he has the guts to think that we are expendable is completely fucking outrageous. And we're gonna fight tooth and nail, especially this mayor. We're gonna fight tooth and nail so that we don't lose our funding.
Thank you so much for that. I'm gonna pass it to our last public comment of the evening. And we're going to take some comments online as well.
I really appreciate, really quickly, I was just brought to the microphone by the comment that Grace made about mental health issues. My name is Ruth Lowenthron, she, her pronouns. I work at the Disability Justice Program of New York Lawyers for the Public Interest. We advocate in a host of disability spaces, but we're particularly active in the moment on mental health issues and the crisis response system that is wholly broken. And the reason it's broken is because police do the responding and then police do the killing. And I'm sure you've read about the horrors of that and how much harder it's visited upon people with mental health conditions who are also people of color. And I think it also hooks in very well to the general concern of this room about why we are just continuing to fund the police and fund the police and fund the police. Well, this is one area where if we take mental health crisis response away from them, as other cities across the country and across the world have done, we don't need to fund them as much in this area. And I just thought that, for sure, and I appreciate it, and I just thought I'd leave you, since everyone loves action items, June 26th, 10 a.m., there is a city council hearing about the Be Heard program. It's the city's attempt to bring about a non-police response. I could go on forever about how awful it is, but it is better than the alternative. And what we're fighting for at the moment is to restore those cuts to that program, another program that's been cut, a non-police program that's been cut, and also to bring in peers, individuals with lived mental health experience as part of the team. So if people could come out for that, and there'll be a demonstration at 9 that day on the City Hall steps. And thank you so much, I appreciate that.
Thank you so much to all of our speakers and people who gave testimonials. We just have a couple comments I'm gonna read from our Zoom. One is, why are you pitting COVID services and STI and HIV services against each other when all of the services are desperately needed by New Yorkers? And then another, our final comment of this section is, will NYC DOHMH provide free N95 and KN95 masks to the public? Will NYC DOHMH provide free rapid COVID tests to the public? Does anyone have an answer to that number?
Feel comfortable answering? You can say no.
It's an important question. I just want to during the pandemic, when the city was distributing masks and free COVID tests, most of that was actually being distributed by other city agencies, and it was all done with federal funding and FEMA funding related to the pandemic. So we no longer have the resources to do the distribution of masks and the COVID tests. The other thing is, our guidance around how to protect yourself, how to protect your communities, none of that has changed. And so we're continuing to share that message, but I really appreciate the people here who are also shouting that message as well to help people understand what they need to do to protect themselves. So thank you.
Thank you. I'm going to pass it now to Jake, who's going to help lead us in some brainstorming for how we can put all of these really important statements and questions and demands to action.
Yeah, so this is hopefully going to be like the most act up-y section because I really just want to get all of you very angry. So this is kind of going to be guided comments with three main categories. The first is if you have a specific idea for an action that could help to get this funding back, especially the $5 million for HIV funding, but generally to get more funding to DOHMH to continue these services. That's number one, specific actions. Number two is, what are you pissed off about this stuff? We want to just compile a list of the things that are pain points for our community. So, do you hate that we don't have access to free masks anymore? Do you hate that the clinics are closing? I just want you to raise your hand and say that stuff. And the third one is, if there's stuff that you still have questions about, that you're just like, what the fuck, I have no idea what's happening. Whatever those questions are, we want you to say those, because then we want to figure out actions that can answer those questions. Does that make sense? So, has anybody been sitting on something that they're pissed off about and would like to just raise their hand? Okay, I see one over there.
Okay, so you went over the numbers, and when it comes to MPOX, we're talking about it was the end of April. I think the numbers for this year are already 185, or about that, Sarah. So is that New York, or is that the country total?
No, New York.
Well, God damn it. Thank you.
Please raise your hand if you want to.
Anybody else? It's free brainstorming. Do you want to see us storm the city hall offices? Do you want to see us? Yeah. Okay, I got some blues. There's one hand.
I did just want to make one more point. A similarity between HIV and COVID that I don't think really gets talked about enough is the way that people talk about them. People talk about them in the past tense. People talk about during the pandemic. People talk about during the AIDS crisis. Those things are ongoing. They're not done yet. Both viruses still exist. They're still spreading. There's still a crisis. It's still a pandemic. If you go on the Wikipedia page for the list of pandemics and epidemics, both of them are in the top 5, and both of them are the only ones that are bold because they're still going on. And I think that's part of it as well. The city health officials you guys have been talking about, we're pivoting, the federal government gave us money because it was from an emergency, and people have been talking in the press, in public comments, just as part of the discourse, as they mentioned earlier, that COVID is now endemic, which I like the way that they put it, is that just means it's a poor people problem, because that is what the word endemic means, right? It means that certain people are just going to suffer from this, and we've accepted that. That's what endemic really means. And there's been a discussion of how the virus is transitioning into this phase of endemicity, but we don't talk about what that looks like. How do we respond to a world with endemic SARS-CoV-2? What does that world look like? What do we do for it? We have an entire infrastructure about how we deal with things like influenza. There's a whole structure for that. There's a whole protocol. There's vaccination campaigns. There's all of this stuff, and nobody ever talked about how we do this for COVID. Even though we're trying to compare it to the flu, we're trying to say it's like the flu, even though it still kills more people than the flu. So why don't we talk about treating it like the flu? We treat it like it doesn't even exist. We treat it like it's not even around anymore, like it's gone. It's not gone. That's what I have to say.
I'd like to say specifically to those that, in one way or another, work for the Adams administration, is a demand to be anti-genocide in every single facet of your work, of your life. I am sure as health employees who care about public health, it is deeply saddening to work for an administration that is funneling all of the money that should be going towards healthcare to the police. And I specifically embolden y'all to decolonize your workplaces, to decolonize your minds, to be anti-genocide in every area you can be. The idea of COVID clinics or COVID care and STI care not being able to overlap, frankly, it's bullshit. Y'all work in the same fucking place, talk to each other, like build coalition with each other. I know the bureaucracy is there to keep us from working together. Please, I urge y'all to find ways to collaborate, to resist. Thank you.
Hi, hello. I'm Jazz. I've lived in New York my whole life. And something that I'm angry about, it's COVID comment as well, is the egregious way that the hospitals and other facilities where we go to get care are pretending like there are no things that they can do, or pretending like long COVID is not real. Every time I go into a medical establishment, I have to start from square one and explain why they need to put a freaking mask on in an appointment with me. And it's ridiculous. And there's messaging that should be required in those facilities. And I know that all of this costs money, making meetings and making requirements, like none of it's free, but it must be cheaper than the PPE that you supposedly can't afford. This is the richest city, one of the richest cities in the world. Like, okay, some of the money is being diverted, like Maddie just said, but not all of it. So why aren't we talking to medical professionals? What is the Hippocratic Oath anymore? Like, yeah, you know, it's a hypocritical oath at this point. They're not doing the basic, and they're backpedaling to like we don't know anything about how science works anymore. It's maddening, and it's costing lives. It's costing people's mental health. We're being ostracized for it. We're not getting proper treatment, and the messaging is not getting to the professionals that could help us, could make those situations better. So please start doing something about that too.
Thank you. We're going to take 2 more comments from tonight.
I think one of the biggest problems is that the public does not know the statistics because they're not being reported anyplace that I can find it. And I think picking a target, and I suggest a media target, or a media target that thinks of itself as progressive, like MSNBC, and really targeting them. Why are they not telling the truth about what is happening today? Public does not know it, and that's why they talk about like it's over. That's a business decision, that's not a health decision.
Thank you so much, gentlemen. And we're going to take our last comment for the evening before we wrap things up.
So I'm mad, and my anger really is coming down to, I guess, my generation, millennials and Gen Z, and I think just the lack of awareness or wanting to know our past. You know, I have so many friends that have lost so many of their dear friends in the 70s, in the 80s and 90s. In my generation, and we just go around, we pretend that everything is good and there's no HIV still going on. And I think the big thing is that what's being taught in school, how is healthcare being taught in school? Why are kids feeling that everything's okay now to like pretend like no one's gonna get tested anymore, and we don't preach condom usage and PrEP for all. We still have so many young people are being infected with HIV. And we should have been trying to turn that curve already, and we're turning backwards because we're not educating our youth anymore, and we're refusing to listen to people who suffered. and we're going to repeat the same mistakes over again and fall into this deep hole because we're lost. I don't know. I feel like we're lost, and there just needs to be. We need to talk, and we need to educate, and we need the younger queer generation that refuses to come to meetings like this to know that there's an ACT UP, that GMHC still exists, that all these organizations that fought so hard for them, you know, it's important, and I just have to stress that importance. Yeah.
Thank you. What a great way to close it out as I plug in ways that all of us can continue to get involved. So as a reminder, ACT UP is still fucking here, y'all. And we still meet every fucking Monday on Zoom and right here at the center. So who in the room am I gonna see this upcoming Monday at 7 p.m. on Zoom or in the center? Make some noise. Great. And also, as we've been plugging this whole night, I'm going to plug it one last time. We have our ACT UP 2024 Pride Health Fair on June 30th. That is in Washington Square Park on the south side, right outside the church. And that is going to be from 12 to 5 p.m. We're going to have incredible healthcare resources and organizations, and I can't wait to see.
Music and fun stuff.
And fun stuff, and fun people. And also, you don't have to limit your Pride Health. You can pregame the Pride Health Fair right here tonight by picking up some of the zines we'll have available. That includes What's Up with COVID and How to Protect Yourself, PrEP and PEP, HRT and PrEP, How to Use Fentanyl Test Strips, How to Use Narcan, and STI testing in NYC. You can pick up all of those zines in the back, as well as some gorgeous hot pink masks, as well as some rapid tests, I believe, from Mike over here in the back. And Marcelo, our ACT UP member, also felt really generous and brought some buttons, so grab those while you still can, and stickers. And we'll see you all on Monday, hopefully, and this upcoming Pride season. And to close us out, can I get one last one big chant in the room and on Zoom? Feel free to unmute yourself too. For ACT UP, Fight Back, and AIDS. On 3. 1, 2, 3. ACT UP, Fight Back.